Hi, everyone, and welcome to the American Ambulance EMS podcast. I'm Dr. Danielle Campaign, American Ambulance's medical director. I'm here with our fantastic co-hosts, Dr. Sajid Bhakta and Dr. Patil Armenian.
Hi, everyone.
Hello.
Today, we're going to be talking about neonatal resuscitation.
It's estimated that in the United States, about 10% of all newborns need some intervention, and 1% will require extensive resuscitative measures at delivery. There are a few factors that might predict a baby requiring resuscitation. From the maternal side, this includes advanced age, so a mom who's over the age of 40, any known smoking, drug, alcohol abuse, severe chronic medical conditions, severe gestational complications like preeclampsia or gestational diabetes, and then multiple gestation, as we saw earlier. From the fetal side, if the fetus is known to be very premature or has any known congenital abnormalities, this will make this a high-risk delivery. And then within the delivery period itself, if the patient has a breech presentation or a footling presentation, if there's meconium delivery, if there's a prolapsed cord or a nuchal cord, then these all make the chance for needing resuscitation higher. Of course, as the EMS provider, we don't always have the time or the luxury to know all about our patients. However, having some of these things in the back of your mind will help you prepare for the worst case scenario. Remember that you will be dealing with a new patient as the baby comes out. If your call was originally for a pregnant woman who then delivers an infant, you now have 2 patients. Or in the case of a twin delivery, you now have 3 patients. And ideally, there would be one provider or one team watching over each patient. And we understand that most crews will have limited hands, but use every resource you have available and don't forget to care for each one of your patients.
Patil, kick us off on the assessment.
There's a standardized assessment tool to evaluate neonates called the APGAR score. And this isn't crucial for everyone to memorize, but it's helpful to know the categories and what constitutes normal so that you can recognize the abnormal. So briefly, APGAR stands for appearance, pulse, grimace, activity, and respiration.
The APGAR score was invented in 1952 by anesthesiologist Virginia APGAR. It is a scoring system ranging from 0 to 10 and is calculated by evaluating the newborn based on 5 criteria. Each of these criteria can be allocated a score from 0 to 2, and then the sum of these criteria will give you the total APGAR score. In the original article published by Virginia APGAR, the original components of the score were color, heart rate, reflex irritability, muscle tone, and respiratory effort. However, there is an easier way to remember these criteria by remembering the mnemonic APGAR for appearance, pulse, grimace, activity, and respirations. Typically, the APGAR score is calculated at 1 and 5 minutes after birth. If the score is low, you usually repeat the score later. A score of 7 and above is generally normal. Scores less than 7 are low and suggest distress of the newborn that requires some intervention, for example suctioning or stimulation. Although APGAR scores are not used to determine morbidity or mortality, lower scores are typically thought to correlate with more severe outcomes. For example, scores of 3 that are persistent can indicate long-term sequelae such as neurologic damage. However, ultimately, the purpose of the APGAR score is to determine when emergent interventions are necessary. The APGAR score is as follows. You will take a look at the newborn's appearance. If they are blue or pale, you give them 0 points. Blue extremities but a pink body, you'll give them 1 point. And you will award 2 points if the body and extremities of the newborn are pink without any cyanosis. For pulse, if it is absent, you score 0 points. If the pulse is less than 100 beats per minute, you'll score 1 point. And in the ideal situation, the newborn's heart rate should be greater than 100 beats per minute, awarding them 2 points. For grimace, you award 0 points if there is no response to stimulation, or the baby is floppy. 1 point is awarded for grimace on suction or aggressive stimulation. And again, ideally, if the baby is crying on stimulation, you award them 2 points. For activity, if the newborn is not moving, you of course award them 0 points. If there's some flexion of the arms and legs, you award them 1 point. If there is active flexion against resistance, you award 2 points. For respirations, if they're absent, you award 0 points. For weak, irregular, or slow respirations, 1 point is awarded. And if the baby is strongly crying, you give them 2 points.
Another simpler method to determine if you have a healthy baby is the following 3 questions. 1. Is the baby full term? 2. Is the baby breathing and crying? 3. Does the baby have good muscle tone? If the answer to all 3 of these questions is yes, then the baby may stay with the mother. If any answer is no, the baby will need further evaluation and transport.
Sajin, let's talk about the management of this baby.
So again, we want to keep things as simple as possible. If the neonate does not appear to be active, healthy, vigorous, using the criteria that Patil just mentioned, it is time to consider some management. So there are 3 major phases of care. First is warming and stimulating. 2 is assisting respirations. And then 3 is CPR, which includes chest compressions and medications. So breaking those down a little bit more, step 1 is warming, stimulating, and assessing the breathing. All babies should be assessed for spontaneous respirations and have a very low threshold, even if the baby initially appears well, to perform simple maneuvers like drying, warming, and stimulating. And so you do this by grabbing a warm blanket if you can, keeping the head covered if you can, and gently rubbing the chest, head, and back with that warm blanket, and that can help induce respirations and crying. Step 2, if there are no signs of distress, just basically continue to transport and continue close monitoring. If there are signs of respiratory distress, the next step would be to clear the airway of any secretions or meconium using a bulb syringe, and then assisting respirations with positive pressure ventilation or CPAP, as we will discuss later. The next step is assessing the heart rate and potentially continuing on to full CPR. It's extremely helpful if you have access to neonatal cardiac monitoring leads. This will give you a very accurate heart rate. Another way to assess the heart rate is to place your fingertips at the base of the umbilical cord, and you'll actually feel the pulsations that you can measure or count out on a watch. You can also, if you have the availability and the tools, place a pulse oximeter on the right hand to help measure the pulse. And remember, a healthy infant will have a heart rate greater than 100. A heart rate between 60 and 100 will require some respiratory intervention. And then a heart rate less than 60 warrants initiation of chest compressions and additional medications such as epinephrine or IV fluids.
So speaking of SEMSA and our local protocols, Patil, let's take us through.
Okay, so for our local protocols, the standing orders in the beginning, it just starts off with airway, like we've been talking about. Suction nasopharynx first, then mouth with the bulb syringe, and position the airway in that sniffing position. Warm is number 2. Dry and keep warm with either a warm blanket or a dry towel. Cover the infant's head and stimulate by drying vigorously, including the head, back, and chest. And then assess. So evaluate breathing and heart rate. Perform your APGAR scores 1 and 5 minutes after delivery. And do not delay resuscitative measures to score the patient. So really just observe the patient. Don't stop anything because you're trying to calculate the APGAR number. At that point, you're basically going to figure out what the heart rate is, and that's going to change the trajectory of your plan. So if heart rate is greater than 100, the heart rate's 80 to 100, 60 to 80, or under 60. So we have those 4 categories. Now, if the heart rate is greater than 100, then you're assessing their color. And if there's any peripheral cyanosis, you give 100% oxygen via mask or blow-by, and you transport and you continue to reassess. Now, if at 5 minutes their APGAR score is 7 or less, then you should perform a heel stick and check their glucose. If it's less than 40, you can give 0.15 milligrams of glucagon IM. Now, if the heart rate's 80 to 100, again, we're going to do the same thing with, giving oxygen via mask or blow-by, stimulate, and reassess. If after 30 seconds of oxygen and stimulation, the heart rate is still less than 100, begin assisted ventilation with 100% oxygen via bag valve mask at 40 to 60 breaths per minute. And that's going to be a stat transport, and you're going to reassess frequently heart rate and respirations en route. At this point, if there's any maternal history of narcotic use, then you might consider naloxone, and you're going to contact your base hospital and notify them that you're coming. Now, let's say the heart rate is between 60 and 80 beats per minute. Again, you're going to be giving oxygen. This time, you're just going to start with 100% oxygen via bag valve mask at 40 to 60 breaths per minute. And if there's no increase in heart rate after 30 seconds, then you're actually going to start chest compressions. You'll start CPR at 120 beats per minute. You're going to do a stat transport and notify the hospital of your ETA when the unit is en route, and try to establish IV or IO access with LR-TKO with Volutrol and pediatric tubing. Now, if the heart rate does not increase above 80, then the protocol does state to give epinephrine 0.3 ml of the 1 to 10,000 IV or IO, and you can repeat this in 3 to 5 minutes. The repeat doses are actually 10 times the initial dose. So your repeat IV or IO dose will be 3 milliliters of the 1 to 10,000 formulation. You're going to try to get an AccuCheck by heel stick and give glucose if their heart rate is less than 80. So really in this case, you are going to get an AccuCheck, but you're not going to rely on that. If the heart rate's less than 80, you're just going to give them glucose. And this is going to be 3 milliliters of D50. And you dilute it 1-to-1 with normal saline for a total volume of 6 mLs IV or IO. And that's really because we just can't give super concentrated dextrose to infants. We really have to give them basically D25.
And a lot of systems are having shortages of D50, so you may have D10 or D5 already, so just refer to your protocol. There'll be a cheat sheet in there with what your actual concentration is.
Exactly. Now, again, in this case, you're going to consider naloxone if there's maternal narcotic use history, and you're going to contact the hospital and let them know that you're coming. Our last kind of caveat is kind of the worst case scenario, which is a heart rate less than or equal to 60. And in this case, you're again going to start off with oxygen, 100% oxygen via bag valve mask, 40 to 60 breaths per minute. You will start chest compressions at 120 per minute, stat transport and notifying the hospital when you're en route. You're going to establish IV or IO access and give epinephrine. Again, it's the 0.3 milliliters of the 1 to 10,000 IV or IO, and you can repeat in 3 to 5 minutes. And just as a reminder, your repeat doses are going to be higher, 10 times higher. So it's going to be 3 mLs of epi. Get an AccuCheck, heel stick if possible, and if you have enough people on scene to get that AccuCheck, and you can just give glucose. Again, it's the same dose, 3 mLs of the D50 that you're going to dilute 1-to-1 with NS for a total of 6 mLs IV or IO. Reassess en route, consider naloxone, if history of maternal narcotic use, and contact your base hospital. And there are some useful notes in our protocol, which is the stuff we've already touched on, but the most common cause of neonatal arrest is bradycardia, really due to hypoxia. So this can be prevented by prompt suctioning and assisted respirations. I went through a lot of different subsets right now, but the bottom line is the heart rate is going to help you determine what level of oxygen you're starting at, and if you're starting compressions or not, giving epi or not.
All right, Zajan, take us through termination of resuscitation.
So this is a very challenging thing to think about, and even more challenging to have to do. In most cases, resuscitative efforts should continue throughout the transport until you arrive to a hospital. However, there may be certain cases, such as very rural environments or extreme prematurity, that providers may consider discussing with the parents and possibly terminating resuscitation. Now, resuscitation with no heart rate for over 20 minutes portends a very poor prognosis, and a discussion should take place with the parents regarding termination of care. Additionally, gestational age of less than 23 weeks is typically considered non-viable. In our SEMSA system, we use foot length as an estimation of gestational age. A foot length of less than 33 millimeters correlates with a fetus of approximately 20 weeks gestation, which is generally considered non-viable. If this is the case, CPR should be terminated. But remember, these will be tough decisions to make in the field. Don't hesitate to continue transport until you arrive at the hospital or contact base hospital physician for any clarification.
So let's talk about our take-home points, our summary take-home points. What do we want everyone to remember for neonatal resuscitation? Sajin, kick us off.
You will only be prepared if you have thought about these things ahead of time. So, listening to this podcast, thinking about these things in your head, reviewing your protocols, being familiar with these things will help you in this situation where everything can be very chaotic.
Patil.
Well, my take-home point is in this chaotic, sometimes scary scenario, just go back to your basics, think term, tone, crying, and then that can help you refocus you to your priorities.
And my take-home point is basically respiratory, right, fixes most of this most of the time. So if you end up bagging the patient, just remember it's much faster than an adult, right? We're used to adult resuscitations. This is going to be at 40 to 60 breaths per minute. Thanks, everyone.
Thank you.
Thank you.